Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Jain. Dr. Jain is board certified in internal medicine and cardiology. Dr. Jain attended medical school at the Delhi University, LNJP Hospital in New Delhi, India. He completed his residency at DC General Hospital in Washington, D.C. He went on to complete fellowships at Michael Reese Hospital in Chicago, Illinois, and Ochsner Hospital in New Orleans, Louisiana. Dr. Jain currently serves as the Medical Director of Invasive Vascular Imaging and the Medical Co-Director of the Vascular Services Program.
Good evening. I know it's a little late, and I hope you guys have not had dinner, because otherwise you're going to fall asleep on me. So to keep you awake, I think I have an interesting talk for you. It's sort of long, because there's a lot of information to give on diabetes, and there are a lot of changes that have happened over the last few years with diabetes and heart disease. So you'll have to bear with me, but I promise I'll answer all the questions that you have at the end of the talk. I might go on to Sandy's time of the support group, but she said that was okay. So what is diabetes? Diabetes is a progressive disease in which your body doesn't make or respond properly to insulin. Insulin is a hormone that is made in pancreas, and it's used to convert sugar, starches, and other foods to energy. So if you have diabetes, your blood glucose or sugar levels are high. And so diabetes is defined as a fasting blood glucose of 100 milligram deciliter or more, measured on 2 occasions. There are 2 types of diabetes. Type 1, which appears at younger age groups because the pancreas stops making insulin. So there's total shut-off of pancreas. And the person has to survive on insulin injections. Type 2, which is the most common one, and that is most of the elderly patient population would have, is an adult onset, which appears in middle-aged adults, develops when the body doesn't make enough insulin, or the insulin that it makes is not effective. So it's not the insulin that is doing its job. And the diabetes prevalence over the last few years has been increasing. That is for 2 reasons. One, the obesity problem, the overweight problem, has been getting worse. And that leads to diabetes in some form, and I'll talk to you about that. And second is that the definition of diabetes has changed. It used to be a blood sugar of more than 140 that we used to call patients to be diabetics. Today, anybody above 100, we classify them into the diabetic category. So what has happened in turn is that the patient population that has diabetes has increased, and you can see a graph over here for developed countries, developing countries, and worldwide, that we expect a good 3 to 5% increase in population, which translates to huge numbers in the next 10 to 15 years. So this is what I was talking about as the definition of diabetes. Fasting glucose of more than 100, or a 2-hour post-glucose load of more than 140 is the definition of diabetes today. Between 100 and 140, we call as an impaired fasting glucose. So this is a zone where you can avoid medications if you're aggressive enough with diet and exercise. Now, what I was talking about, the overweight, that is a syndrome called as metabolic syndrome. It occurs with mainly overweight people, and what happens is that they develop insulin resistance. This is what happens with type 2 diabetes also. And they have increase in free fatty acid, which leads to further problems of blood sugar problems, issues with cholesterol, dyslipidemia. They have low good cholesterol, they have high triglycerides, they have issues with blood pressure, they have issues with endothelial dysfunction, that is the lining of the arteries, they don't function properly, and they have kidney issues. This syndrome is called as metabolic syndrome when you have a combination of these things, because all these things lead to plaque buildup or blocking of the arteries, which is what happens with diabetes also. So what we found is that with metabolic syndrome, the cardiovascular mortality, people dying of because of the condition, increases significantly. If the cardiovascular mortality with patients that do not have metabolic syndrome is 2%, the ones that have metabolic syndrome, it is 12%. So it's six-fold higher with metabolic syndrome. And so it's basically important to understand that overweight people, they don't just have weight issues, but they have issues with a lot of other things that affect that have the same effect as diabetes would. So diabetes kills about 60,000 Americans every year. 190,000 die from diabetic complications, which is a key thing, which is what we are going to talk about today. It leads to blindness. It leads to kidney failure. Leads to gangrene in the legs. It increases a risk of stroke by 2.5 times. 2 to 4 times increase in cardiovascular mortality, that is the heart attacks. And diabetes is responsible for 25% of the bypass surgeries that happen. Mortality in diabetes occurs mainly due to heart problems. 70% of the patients with diabetes would die because of heart issues and 30% because of other issues. So diabetes and heart is a huge issue. Okay. This is diabetes and heart disease that occur, and the mortality over 20-year follow-up. What is found that in men and women, it's pretty much the same, that the non-diabetic population, the women do not have heart disease that much. But in the diabetic population, women have the same amount of heart complications as men do. So diabetes somewhat in women takes away the protective effect of the hormones that women have. So mortality in people with diabetes also, this graph basically shows you what causes the death. And like I told you earlier, 40% of the deaths occur because of heart attacks, 15% because of other heart diseases, and the rest of them are because of either diabetic complications like infections and stuff, cancer, stroke, and other complications. The risk of development of heart failure in diabetes is related to the control of diabetes. This is the A1C level, and I hope all of you know what A1C is. I'm sure all of you must have heard about it or had that test. It's basically a test which tells you of how well your diabetes is controlled over a period of time, rather than the doing a fasting blood sugar check on the day of the test, which is what that one test would tell. But A1C tells you about 3 month, gives you a 3-month picture. So if the A1C is less than 7, the risk of heart failure is 4.5%, whereas if it is more than 10, the risk is double. So heart failure incidence, this is different from heart attack, is also worse with diabetes. And if there's improved glycemic control, that reduces the risk of complications. So you've heard both sides of the story, that if the diabetes is uncontrolled, the risks are higher. On the other hand, if you're rewarded, if the diabetes control is good, the risk of having a heart problem also decreases. So there is a good correlation. So every 1% decrease in A1C results in 21% decrease in diabetic-related endpoints, which is complications. It decreases the risk of heart attacks by 14%, decreases the risk of stroke by 12%, and this decreases the risk of microvascular complications, that is blindness, kidney failure, gangrene in the legs and stuff, by 37%. So only 1% decrease can have significant effect. Diabetes does affect the whole body. It causes strokes, it causes heart attacks, it causes kidney failure, it causes gangrene in the legs, it causes erectile dysfunction, causes nerve issues. I'll show you an angiogram from a patient that has diabetes and show you how the arteries are blocked all over the body. This is an angiogram of the heart, and it shows that there is clogging of the arteries significantly all over. You can see here that these arteries are very thin. The arteries should be this black cylinder that you see up here. That is how the arteries should look all the way around. But they are skinny, they are blocked up at multiple areas. This is a typical angiogram of a severe diabetic heart disease. And not only that artery, but this you see in all arteries. This is the artery to the right side. You see blockages all over the place. In this artery, this is the angiogram of a kidney artery, and you see that it is blocked right up here. This is the angiogram of the heart, and you see that the heart muscle is weak. It is not pumping. It should be vigorously pumping and pumping out the blood, but it does not. This is the angiogram of the neck arteries, and this is the same patient. And you can see that there's a tight blockage here. And this is the angiogram of the leg arteries on the same patient. And you see that there is clogging of the arteries all over the place in the body. So this is a tight blockage here. The artery over here is completely blocked. It's 100% blocked. There's barely any flow going to the foot. So the disease is rampant. The disease is sort of everywhere in the body. So if that brings to the thing that if you have diabetes, you need a good vascular checkup, because it's not just checking the heart, but it's checking the circulation of the whole body, because the whole body is affected in some form or the other. So how is coronary artery disease different in diabetics compared to the non-diabetics? Like I just showed you, it is multivessel disease. That means it involves a lot of arteries rather than just one single artery. The disease causes blocking of the arteries diffusely. It just does not block at one area, so it's not easy to fix. If we do angioplasties and surgeries, we want certain area to be diseased, but a healthy area before and after. And we don't find that much in diabetics, that disease, because the disease is diffuse. So fixing becomes an issue. Diabetics don't have the typical symptoms that non-diabetics would have. That means the typical symptoms is having severe chest pain and stuff. In the diabetes, the pain is non-existent at times. They come with shortness of breath, fatigue, because the nerves are dead. And so the pain sensation is not there. It occurs in younger population, more often seen in women, and the worst outcomes despite revascularization. That means despite treating properly, the outcomes are not great. There is more restenosis and worse complications. Now, what happens with diabetes to these arteries? There's a process called as atherosclerosis, which is in simple form plaque buildup. The buildup that occurs in the arteries and clogs up the arteries. That process is called as atherosclerosis. It's a collection of basically cholesterol, cells, blood cells, and scarring of the arteries. So the hypothesis is that this process really is universal. It's not only for that it happens in diabetics, it happens in everybody. And the process starts at birth, believe it or not, that as soon as the baby is born, the arteries feel the blood pressure. And this blood pressure somehow damages the inner lining. And when the inner lining gets damaged, that is what is this endothelial disruption, then this process starts. Though it all depends on how fast this process is. In some people, it is very slow. In others, it's fast. And the faster things happen with patients with diabetes, high blood pressure, high cholesterol. So all these risk factors make this process of atherosclerosis go at a steeper curve. And this is what happens. So there are three linings of the arteries: the endothelium, the inner lining, the muscle lining, which is called as media, and the outer lining, which is fibrous tissue, is called as adventitia. This inner lining, though it is one cell thick, but it is very important because it secretes a lot of hormones and a lot of good things that keep the artery wall from closing down or keeps the process of atherosclerosis from happening. So, but this lining, when it gets damaged, that protective nature is gone. And hence, this process of atherosclerosis starts. And this is what happens when there is damage. The lipid accumulation, that means the cholesterol, starts penetrating through this lining into the wall. And the cells in the wall die. And this death causes liquid formation over here. And this liquid formation increases the pressure on the lining and makes the lining rupture. This rupturing of the lining causes all this grubby material enter the artery lumen, the artery space. And when that happens, this is a sticky material, as you can see, this yellowish material. This attracts the blood cells into this and clogs off the artery. Now, if the artery is completely clogged, that is when you get occlusive thrombus or total shut off of circulation to the tissue beyond that point, and that causes cell death. So if this is happening in the brain, it causes stroke. If this happens in the heart, it causes a heart attack. If this happens in the toes, it causes the gangrene. But the process is the same, whether for all the three regions or any region in the body. If it does not completely close the artery off and still the trickle of blood happens, then what happens is that is lack of blood flow. This lack of blood flow causes the tissue damage but not death. So the tissue damage causes the pain in the heart area. In the brain, it causes mini strokes. In the legs, it causes blocking. Lack of blood causes claudication. Claudication is basically pain in the legs when you walk. You stop walking, the pain goes away. That is claudication. That is because when you walk, you exercise, the tissue needs more blood. Because of the blockage, there is not enough blood coming through because it is obstructing it, and hence you get the pain. The moment you stop, the demand goes down and the pain goes away. Simple. So that is what happens, and it's the same process all over the body. And this is what this material looks like if you were to open the artery and take a look at it. So the key is that this process of atherosclerosis is common all over the body. And the risk factors that make it happen at a faster pace, like I told you, are high blood pressure, high cholesterol, smoking, diabetes. These are the four major risk factors, including family history, which we don't talk about much today because we cannot change it. But down the road, when we have gene modification therapy, then we probably could change the genes. But at this time, we cannot. So there are secondary risk factors: overweight, stress, sedentary lifestyle. As you grow older, female are a little bit more risky, a little more at risk after menopause, after the age of 50, than men are, because the protective nature of hormone is not there, and certain races are more prone to this disease. Diabetes. Let's talk about the risk factors. Blood sugar should be less than 110 at all times. This number should be 100 now. One of the worst risk factors, it is thought that if you have diabetes, we classify you as having had a heart attack, that you are in the same category as of patients who've had a heart attack. So that is one heart attack. So we treat you beyond that. The need for aggressive control of risk factors is very important because diabetes is related with blood pressure and cholesterol. And you need more frequent and complete checkup of circulation, not only the heart, in diabetics. So the A1C number few years ago used to be 7. Today it is 6. We are being very aggressive in managing our diabetics because we know that we can help them more if we aggressively control diabetes. The high blood pressure is equally important, especially for strokes. And there are two components. One is systolic and the other is diastolic. Systolic is the higher one, diastolic is the lower one. Systolic should always be less than 120 to 140. You have a little leeway when you grow older because the arteries get stiffer. And as the arteries get stiffer, they need more pressure to keep the arteries open. And hence, a blood pressure of 140 to 150 on the systolic in elderly folks is okay, whereas in younger folks, it should always be less than 120. The diastolic is the bottom number, and it should always be less than 90, no matter what age. And like I told you, this is thought to be the cause of initial trauma that starts the disease process. In patients with diabetes and cardiovascular disease, what should be the target blood pressure? There was a recent study done, and they looked at blood pressure of 140 or 120. Which one would be better? And this is a study that was just out this year called as ACCORD-BP. It's a multi-center randomized trial, and they looked at this factor of how tight the blood pressure control should be in diabetics. And the follow-up was almost 5 years. And what they found was that the systolic blood pressure, intensive is 140, standard is 120. Intensive is 120, standard is 140. So they were able to control the blood pressure in majority of people at that level, 120 or 140. And what the outcome, non-fatal heart attacks, non-fatal stroke, or cardiovascular death was lower when you had the blood pressure lower at 140 than the standard, which was when it was 120 intensive therapy, the results were better. And that was seen all across the board for strokes or from cardiovascular deaths. So the adverse events, you can see that low blood pressure and syncope were less with intensive therapy compared to the standard therapy. Okay. The kidney dysfunction was also less when you had good control of blood pressure versus not that good of control of blood pressure. Okay. But overall, what we found was that even though you controlled and the few things were better, like hypotension and the kidney function, but overall, there was not that significant a difference between 120 and 140 blood pressure control. So what the study tells us is that you really don't have to be very aggressive in controlling blood pressure to ranges of 120 and take the side effects of medicines. If you can do it easily, do it. But if you cannot do it easily, you don't have to bring the blood pressure down to 120. And the age group of this study population was in the 65 to 75. That's why I said you can tolerate higher blood pressures in older age group. You don't have to be aggressive to bring the blood pressure down. So that is as far as the blood pressure goes with diabetics. Now, cholesterol issues, there are many components, the good, the bad, and the ugly. That means the good is your good cholesterol, which is the HDL, and the bad is the LDL, and the ugly I call as the triglycerides. So these should be very well controlled. Cholesterol should always be less than 200 if no previous heart disease or diabetes. But in diabetics and heart disease patients, it should always be less than 150. So our targets are much stringent when we have diabetes and heart disease. The good cholesterol should always be more than 40. In women less than 50 years old should always be more than 50. And the good cholesterol really helps clean up the arteries. The bad cholesterol should be less than 130 as usual, but today the number is 100. The bad cholesterol should be less than 100, and patients with heart disease or diabetes it should be less than 70. And sometimes it can be very tough to get these numbers. But that is the important thing, that you have to work hard and get to these numbers with diet, exercise, and medications if need be. Triglycerides, the number is 150. It should always be less than that. Okay. In diabetics, what we find is that the triglycerides are generally elevated, the bad cholesterol is elevated, the good cholesterol is low. So diabetes is affecting all these three parameters adversely. This is a study which looked at triglycerides. Because triglycerides are high in diabetics, there was a thought that what if we control cholesterol and triglycerides very aggressively in diabetics, would that help? So not only do we put them on one medicine which controls the cholesterol, but we add a medicine that controls the triglycerides also. So this was a study of statins, which just controls the cholesterol mainly, along with statins plus fibrates, which affects both the triglycerides and the cholesterol. And what they found in this trial, just for the sake of time, I'm going to go to the message, that type 2 diabetics and cardiovascular disease, the combination of fenofibrate and simvastatin did not reduce cardiovascular events. That means you do not need to be, again, aggressive about the triglycerides. You have to be aggressive about the cholesterol. So just giving statins alone and taking the advantages of that one medicine, rather than adding another medicine and taking the side effects of two medicines now, is not worth it. So what I'm telling you here is that, yes, you have to control them, but you don't have to go overboard in controlling them so that you start taking the side effects of medicines. Smoking is an absolute no. There's no discussion on that. So this is the influence of multiple risk factors. I told you just now that there were 4 major risk factors that can be modified. So if somebody has diabetes and risk factors, the risk of having a heart attack is multiplied. So if you have diabetes, which is in blue, and no non-diabetes, so the risk increases with diabetes or no non-diabetes. But if you have diabetes, the risk is much higher. So if you have 1 risk factor, it's doubled, 2 risk factors, it's tripled, and if 3 risk factors along with diabetes, the risk is quadrupled. It's almost a 30 to 40% chance that this person with diabetes, high blood pressure, high cholesterol, and smoking will have a heart attack during their lifetime. It's almost 30 to 40% chance. So if you have risk factors along with diabetes, you have to be very aggressive in controlling these. Diabetes affects the heart in two ways. It affects the small arteries in the heart as well as the big arteries. The big arteries cause the heart attacks because they cause major damage if they're blocked off and cause the heart attack. Whereas if the smaller arteries are clogged, then you don't see the effect on a daily basis. They may cause aches and pains every now and then, which are not typical, and the damage keeps increasing over time. And what it leads to is a weak heart, which we call as cardiomyopathy. And this weak heart then cannot pump blood, and by the time you find out that you have a weak heart, it's a little too late in fixing it. So that is what microvascular complications are of diabetes and macrovascular complications are. How do you find out that you have diabetes? By symptoms. Generally, if your blood sugar is high, you feel thirsty, you feel hungry, and you go to the bathroom more often. So it was usually 3 Ps: polyphagia, polydipsia, and extreme thirst. So weight loss, fatigue, and blurry visions are symptoms associated with high blood sugars. Now, the symptom typical for the heart attack is called as angina, the pain from the heart. The typical pain is a pressure, tightness, squeezing, heaviness, or choking sensation, which radiates down the left arm to the back or to the jaw, occurs with exercise or any kind of stress, and it lasts for a few minutes or until activity ceases. That is the typical chest pain. Unfortunately, in diabetics, you don't see that more often. 30 to 40% of the diabetics they might have had a heart attack and they wouldn't even know about it. They would have damaged 30 to 40% of their heart muscle and would not have an idea that they've done that. So the problem is that because the nerves get damaged, they don't have the sensation of pain. So the way they find out is if they cannot exercise, they cannot walk, they get short of breath when they walk, they get dizzy when they are doing some activity. So these are atypical symptoms. But the important thing is that if you feel that there is a change in your activity level, that means, say you are going 4 blocks of walking to do something, some activity, or you were climbing 20 stairs on a daily basis, and suddenly you realize that you cannot do that. That amount of exertion is becoming difficult to perform. At that point, that's a warning sign. You need to seek help at that point because something has changed. Most of us would ignore it, or most of us will deny it. But that is when you want to seek help in diabetics. The way you diagnose coronary artery disease, that is for diabetics or non-diabetics, is initially you do a EKG. EKG tells you what is happening at that time or what has happened in the past. It does not tell you the future, but it will tell you whether you've had a heart attack most of the time or whether you're having a heart attack. But it will not predict what is going to happen down the future. Stress test, on the other hand, will tell you whether you are at risk of having a heart attack or not. And there are different kinds of stress tests which we can perform, which will give us an idea. And the diagnostic test is really an angiogram. When you go into the artery, and I showed you the pictures from the angiogram, basically you go into the arteries and you inject the dye and you outline the arteries, and that tells you whether there is blockage or not. There are other ways of doing the angiogram these days through CAT scan and MRIs, but they all have issues. The gold standard is. So this is a stress test that shows how an echo stress test is done by doing an ultrasound with a patient walking on the treadmill. This is the myocardial scan that tells you where there's lack of blood flow to the heart muscle, and that gives you an indirect idea of where the blockages are. And this is a CAT scan angiogram, which can light up the arteries and show you the pictures of the arteries like we see on the angiogram, but not as clear and does not give us all the information that an angiogram would give. And this is a conventional angiogram that we do most of the time. How do you manage diabetes and heart disease? The key is diet and exercise before you start using medicines or any devices or surgery. So the major mainstay of treating diabetes is diet and exercise. And the management of metabolic syndrome. So if a patient may not have diabetes but has obesity and has high blood pressure, has hypertriglyceridemia, then you want to treat that patient almost as diabetes, though they don't qualify for that blood sugar level of diabetes. So management of metabolic syndrome is very important. Weight control enhances, by decreasing weight, you enhance the LDL lowering and reduce all the risk factors. Physical activity, that is exercise, reduces the LDL, the good cholesterol, the bad cholesterol, and increases the good cholesterol. Okay, so by treating the cholesterol issues, you indirectly treat high blood pressure also. So metabolic benefits of weight loss are significant. This reverses the change of insulin resistance and metabolic syndrome. So if you have diabetes, like I told you, you have insulin resistance, you lose weight, the insulin resistance is reversible to some extent. Also, exercise and losing weight increases your good cholesterol. So you can see an increase of 1.6 milligrams per deciliter from a 10-pound weight loss. So question is there a treatment that can improve all the 5 features of metabolic syndrome at once? And this treatment is thought to be therapeutic lifestyle change. There was a huge study that was done in Sweden, and what they found was that diet change to improve cholesterol profile and daily physical activity and weight control leads to big rewards. This was a 522 middle-aged overweight 172 men and 350 women study, which were studied over 3.2 years. And the intervention group was counseling, reducing weight, total intake of fat and saturated fats were decreased, and increased uptake of fiber and physical activity. This was reported in 2001. And what they found was that by treating the metabolic syndrome, after 4 years of risk of diabetes reduced by 58%, these obese patients did not get diabetes half the time. So you could prevent them from having diabetes. And the intervention control basically brought the risk of diabetes down to 11%. So a 4.2 kg, about 9 pounds in the diet and exercise group compared to 0.8 kilograms weight loss was seen in this study just with diet and exercise. And this 9-pound translated to a 58% benefit. So there have been multiple other studies beyond that which have shown that diet and exercise, that is therapeutic lifestyle change, helps tremendously. Also, there was another study during that time in 2004 which showed that if you aggressively control cholesterol, you can reverse the process of atherosclerosis. You can reverse this process of plaque buildup. This was the first time it was shown and well proved by looking inside the arteries. So giving a cholesterol medicine which is moderate versus a strong cholesterol medicine, that is 40 milligrams of pravastatin versus 80 milligrams of atorvastatin, which is 4 times more powerful than this drug. What they found was by looking inside the arteries with an ultrasound and seeing this plaque buildup inside the arteries, they quantified that. And they repeated the study after a few years. And what they found was that with the medication, the 2 medicines, you drop the cholesterol levels significantly. At the same time, the reduction in the plaque was significant, 46% versus 25%. And the change in atheroma, the volume change in atheroma, for the first time they realized that you could decrease, not only stop the process, but you could decrease the plaque. So that means if the blockage was 50% at time 0, at end of the study, it was 30% or 20%. So the theory behind this all is that you want to stabilize the plaque. What I showed you earlier was that when the plaque builds up, it ruptures the artery. And this rupturing causes the problem. So if you can stabilize this process over here, instead of being liquid, which has high pressure, it becomes solid, which does not exert any pressure. Then this rupture does not happen. So that is called as plaque stabilization. So even if the plaque stays at 0 level, then it is stable. It will not cause a major problem like heart attack or strokes. On the other hand, if you decrease this further, then not only have you taken away the factor of rupturing, but at the same time you've increased the blood flow. So any damage that has been done to the cells beyond can recover. So you are helping further this process. So controlling cholesterol or lipid is very important, but controlling aggressively may help more. That is what this study pointed out to. So basically, what are the strategies of for reduction of diabetes complication? Microvascular complications, like I said, you want to aggressively screen the patients and you want to improve the metabolic control. Macrovascular, that is heart attack, strokes, you want to improve the blood sugar control. Prevention of type 2 diabetes, that means you want to prevent the diabetes from happening, and aggressive treatment of established cardiovascular risk factors in diabetics and possibly pre-diabetic subjects. So not only in diabetics, but pre-diabetics also. That means if somebody has a blood sugar of 110, you want to say, I am not diabetic, or I can easily control with diet. But if you have that 110 blood sugar, along with high blood pressure, along with cholesterol that is uh, above the levels, then you want to control everything, because that 110 becomes very important. On the other hand, if you had just diabetes with 110, blood sugar with 110, and everything else was fine, then it is not that bad. It's not that significant. So that's why it's important. So this is a study that was done to show if you are aggressively controlling glucose versus not aggressively controlling glucose. I told you about aggressive control of blood pressure before. I told you about aggressive control about cholesterol before. Now aggressive control of sugars. This was a study that was done and reported in 2009. And what it showed basically was that if you control blood sugars aggressively, intensively, it does benefit. It does help with strokes, it helps with heart attacks, and decreases the all-cause mortality significantly. So intensive control of blood sugars does help and significantly reduces coronary events. So controlling blood sugars is definitely helpful. Now a few words about medications that we can use. Aspirin in diabetics is helpful. It is helpful in patients without diabetes also, but aspirin with diabetics increases the chances of survival. So chances of surviving are higher if you're on aspirin compared to if you're not on aspirin. The dose of aspirin today that is needed is 81 milligrams. A baby aspirin is good enough. You don't have to take a full aspirin to see these benefits. There is a drug group called as ACE inhibitors. You may have heard about these: lisinopril, Diovan, losartan, Cozart. All of them belong to these. These group of drugs protect the kidneys in diabetics. So because, like I told you earlier, diabetes can affect the kidneys, these drugs have protective effect over the kidneys with diabetics. And they've shown to decrease the risk of heart attacks, strokes, cardiovascular deaths, especially in diabetic group. And the third group of drugs is beta blockers like metoprolol, atenolol. You may have heard about that. This is a group of drug that is shown to increase the survival in patients with diabetics because they decrease the incidence of deaths after heart attack. So these are the three major groups that you need to think about when you have problems with heart and diabetes, and we use these drugs quite commonly. And what this slide is showing you is basically that if you treat patients intensively versus conventional therapy, the benefits are much higher. So that means the risk of having a cardiac event is much lower if you treat patients intensively. There are other ways of treating other than medicines. We do this procedure called as angioplasty, which is basically opening up the heart arteries. And then we do surgeries, that is bypass. Both of these things are helping us buy time. They do not cure the disease. What we are doing is we are relieving the obstruction so that we can create a better channel for the blood flow. So the disease process still remains there. So you have to treat the disease with diet, exercise, and medications. But if you have a problem and you want to fix, which will buy you time, you have angioplasty, you have surgery. Angioplasty and stenting is what we do. We have cutters, we have roto-rooters, lasers, stents, whatever a plumber carries, we carry. Okay. So it's basically unclogging the drain pipes in the heart. So there are other devices that are coming in the horizon. We can now look at things when we fix them, not only by just injecting the dye, we can visualize them with ultrasound, with a modality called as OCT, which is laser waves. So we can see what we are doing and we can treat it in a better way. There are drug therapies that are coming. There are gene therapies that are coming. That means we can inject the treatment into the tissue, and hopefully we can rejuvenate the dead cells. And all angiogenesis is the modality that's called. It is all in the horizon. Don't know when, but it's been going on for years. So it's not that easy, but I'm sure it'll happen sometime in the next 5 to 10 years. So diabetes does double the risk for MI mortality despite advances in cardiac care. We have improved tremendously in the last 25 to 30 years. In my time, that is the last 20 years I've been practicing in this area, I know that the risk of a patient dying from a heart attack has decreased considerably with all the improvements that have happened. And this is the time era, you see, that early mortality from acute heart attack was 50% initially in the diabetic group. And in the 60s and 80s, we brought it down to 30%. In the 84 to 2000, that is the blood clot dissolving era, we brought it down to 10%. And today, we have it down to 5 to 6%. So over the last 50 years, we've decreased it from 50% to 5%. So I think there is tremendous increase, and there is still some potential to bring this down further. So there are huge advances that have happened in the area of cardiac care, especially in diabetic population. Stenting, like I told you, we can stent the arteries and open the arteries. Diabetic populations, the results are poorer compared to the non-diabetic population. So the diabetes, everything is adverse, everything is worse. And so you have to be much more aggressive. So ADA recommends a general A1C target of 7%, less than 7%, but the goal of therapy for the individual patient is to achieve A1C as close to normal, which is less than 6%, as possible without hypoglycemia. This is the number that one should strive for. More stringent glycemic goals may reduce the risk of serious diabetes-related complication. So important thing. Less stringent treatment goals may be appropriate for certain patient population and patients with severe or more frequent hypoglycemia. And that is an important statement because the risk of low blood sugar is much higher than the risk of high blood sugar. So you don't want to have sugars of 30s, 40s, and 50s because that is a problem. That's a huge problem. One can die from that. One will not die from a blood sugar of 150, 180, but 30 or 40 can cause huge problems. So you have to be careful. You have to balance this out. You want to control it aggressively, but you don't want to be too aggressive. So you should seek help, and I think what Sandy does for the diabetic program here and what the endocrinologists and all do, it's very important that you seek their help because they will tell you where it's safe, especially in the elderly population. Patients that have are above 80, 85, patients are living longer, so they have issues with memory. And if you're using insulin, if you're using diabetes drugs, and you take the wrong dosage, that can be a disaster. So it should be all individualized. So I'm not saying that a patient who's 90 years old has diabetes, high blood pressure, high cholesterol, I would be as aggressive as I would be in a 50-year-old. Because these complications happen over time. They don't happen overnight. So if somebody's going to live for 3 to 5 years, I'd rather have them enjoy life and yes, control it, but not be aggressive. But on the other hand, a person that's 50 years old who's going to have another 25, 30 years of productive life, you want to be aggressive. You don't want them to have a problem during those 20, 25 years. So you have to individualize. So pearls to take home is early diagnosis or even preempt diagnosis. What I mean by that is that if you have a family history of diabetes, you have a family history of heart disease, you have a family history of high cholesterol, then you have a good chance that you will have that problem. So if you have obesity, you may not have high blood pressure, may not have a high cholesterol today, but over time you will have it. So if you can preempt, that means you can start working on it before you have it, it helps a lot. Aggressive management of diabetes is very important. And if you have these, you need a complete checkup. You should not be just saying, going to the physician, they're taking their blood pressure, measuring your sugars, and saying everything is fine. You want a complete checkup after a certain age, like 35, 40 years old. You need a vascular checkup from head to toe, not just the heart, not just doing an EKG and saying your heart is fine. That is not good, because EKG will tell you so much only. So you want to make sure that you're not developing blockages anywhere in the body. Okay. So if you do know you have diabetes, do not procrastinate, avoid denial, seek help. Sooner the better. Time prevents complications. So can you prevent a heart attack in diabetics? I think yes. The question is, do you really want to? Because you have to do a lot to do that. Thank you.